Thank you very much, Catherine and Margot, for the wonderful talk this afternoon. My name is Timmy Frawley. I am an associate professor in mental health nursing, and I am also a member of the University College Dublin Neurodiversity Working Group. And I'm delighted to be joined here by Eva, Jess, Bernadette, and Connor for our panel discussion. And I'm sure, like me, you've all been tuned in and at various points during the day listening to the really excellent talks. So before we get into it, just to let you know very briefly about what we've been doing in UCD, together with a number of colleagues led by Dr. Blonagh Gavin, an associate professor in child and adolescent psychiatry, we have been undertaking a series of projects, and these projects include conferences such as this one in collaboration with the Institute of Neurodiversity, Autistic Doctors International, ADHD Ireland, and Neurodiversity Hub, of course, in Australia. We have also a monthly masterclass series on the last Thursday of every month. We have a professional diploma in neurodiversity, and we also have a Making UCD a Neurodiversity Friendly Campus project, which we're all very excited about. And we have some recommendations forthcoming from that. So that's just a sample of some of the things we do. And of course, we wouldn't be able to do any of it without Miss Beth Kilkenny, one of our senior projects managers. But back to the focus of today, if I may, and just to begin our panel discussion by maybe asking some individually oriented questions, but of course, we will be inviting everybody into the discussion. So I'll start off in alphabetical order with a question for Bernadette. And Bernadette, when I was listening to your talk, I mean, the issue of sensory overload is one which I think is so important. And particularly in hospital settings, in inpatient settings, be they mental health or general adult, or even child, pediatric, what key actions do you feel need to be taken to improve our existing premises to make them more friendly for people who have sensory issues?
Thank you, Timmy. Wow, that's a very difficult question. And I think it was important if you were able to listen to Alexis' talk, and please read her book, because you see what happens for the patient when they're exposed to different incongruities, the problem. I know I've been working in big hospital, in big county hospital in Los Angeles. The psyche and the inpatient are sensory health for the staff too, not only of course, but that means the staff isn't burned out and it's very hard for everybody. So I think one question is, how much money is a hospital ready to do? So we have individual rooms that are not scary rooms, right? Because if you are in a room to calm down and it's a bright light and it's noisy and you have a table on which you may be put in restraint eventually at another place which bring terrors. So there's things to be done. And I know at UCLA, at the NPI, that they try to conceive rooms that are sensory really positive. That costs money, and we know our system is not ready for that. I think Alexia had a very good point for all of us, that what we can do is the way we explain what's going on, the way we approach the person, the way we don't touch, don't make eye contact, don't force that, right? Don't push them to get out of a state. And so on our side already, there's so much we can do. First, control ourselves, because it's a very stressful situation. I think of a meltdown, for instance. And I think that's the first part that everybody can do, being aware or say turn off the light or turn the light down, right? If it's not scary for the patient. My tone of voice should be very careful. Tell the rest of the team to be very careful. So I think information is already so important. And that's why I was pushing the information at the sensoriety level. And every person is different. So ask questions and be respectful.
That's a great answer, Bernadette. Would anyone else like to add to what Bernadette has said on the topic of sensory overload? Connor and then Jess.
Thanks to me, and thanks, Bernadette. Yeah, I was just thinking back to a patient I saw last year in an acute psychiatric ward in Leeds. I was thinking maybe I wouldn't name and shame the trust because it's actually the trust I work in. But anyway, we were seeing, it was a young girl, about 19, 20, and her mum was there to give us some developmental history in a very busy acute psychiatric ward. And I remember it very well because we were put into the main interview room was out of action, and they put us into this almost like a broom closet with no windows, with an extremely loud, clanky air conditioning unit, very hot, and no soundproofing, so we could hear. There was a lot of commotion on the ward, a lot of agitated patients. And then about literally 5 or 6 occasions during the interview, we were interrupted by other patients opening the door. And so they clocked that I was a psychiatrist, so people were coming in and sort of asking me for medication and Section 17 leave and things like that, even though I didn't work on the ward. So it was almost a catalogue of all the things that can be a problem for autistic people in inpatient wards. There was the temperature, the windowlessness, the noise, the interruptions, the sort of sense of slightly unmanaged chaos going on in the background. So we did sort of raise that with our trust and the ward manager. And we've put in place a program now in collaboration with the local autism hub of conducting sensory audits across the inpatient wards. And so I think that's probably the first step from our point of view, is getting some service users and experts by experience involved and getting them on the ground and really starting to analyze what the issues are. And then, of course, the next step is trying to solve some of those issues, which is far from trivial. It's very difficult to retrofit hospital wards. But yeah, I think that first step is to do an audit of the environment, and preferably with autistic people involved.
Sure, Connor, and I think you've really neatly encapsulated some of the challenges and the circumstances in which people work and people receive treatment and care. And this, of course, affects everyone, but in particular, autistic people are people who identify as neurodivergent. So those remedial actions sound really encouraging. How we do it and how we roll it out quickly enough is the key concern, but I think you've really captured it. Jess, you wanted to come in as well.
Oh, yes. I just wanted to say, and I think Alexis alluded to this in their very powerful talk, was the importance of curiosity. One size doesn't fit all, and one person's preference could be someone else's, real soothing love. So I think it's important to not make assumptions and to ask people about their preferences, and also but to really try and do the basics, as in terms of making sure that the organized chaos is more organized, and that there is a nice, quiet, safe space to talk, but really finding out from each individual what it is that they need at that particular time. And for some people, what might be soothing in one circumstances is really not great in another. So I think the work that Mary and colleagues have done on the space framework is a really useful tool to have with you at all times in terms of thinking about how to make places as accessible and inclusive to all.
Mm-hmm. And it's about that empowerment, it's about choice, it's about the person-centered approach, and asking people as part of a robust care planning process, I like that, Jess. Just to move ahead, so Bernadette, we've put a question to you and opened it out. Let's put one to Eva. Eva, your research area, it's not one I'm hugely familiar with, but the importance of biomarkers, for instance, was not lost on me. From a bench to bedside perspective, what would you like to see changing in practice in the next 2 to 5 years?
That's another very interesting and difficult question. I think it's again starting off with the basics. Really, is a place like this conference, for example, is so valuable to learn about different people's perspectives, to understand different people's priorities, people who come from different backgrounds. And are sensitive to, different needs, or some of it is maybe more in common, and some of it is there's been so much new that I learned today during this conference. And I think similar to the question about sensory sensitivities, it's asking questions and also listening really to the other person and trying to integrate then what matters most to the others, to see to what extent this can be used and integrated in one's own research. So, for example, sensory processing is a great example, because this is really something that we've moved to more and more now since we've become aware how central this is. And if anything, this might be sensory processing, sleep, might be the issues where people are more interested in having a treatment, whereas in other areas people might have very different opinions or variable opinions. But sensory and sleep, there's a lot more consensus that there is intervention desired.
Sure, and from what you're saying, I'm also hearing, the importance of co-commissioning of work, the co-production of work, the co-delivery of work, but also the co-receiving of conferences like this as well, and hearing from different perspectives. Not every perspective we might agree with, but I think it's that piece about being able to listen and to hear the different points of view. Would anyone else like to add to what Eva has said?
Maybe just briefly, Timmy, I'm sorry, I could add this, is that whatever improvement we do, and that's been the case with disability rights since the beginning, the entire society will benefit from it. I mean, everybody will benefit from a quieter emergency room, for night shade when they are in an ICU. Or I was thinking, just, give ears protections. So I feel that we want to justify that at the political level or the financial level. You probably will have less burned out in a place where people are not opening the door constantly. So it's very important to put in the context also. But autistic people may be the canary in the coal mine or the gold mine of the healthcare system, and say, okay, this is a problem, and we can really not survive.
Yeah, and I must say, Bernadette, when yourself and Connor were speaking earlier, it really resonated with me that actually everybody would benefit from these developments, and the importance of universality in how we design services, health services in particular, really shone through. I will be taking a look at the Q&A in a few minutes to see if there are any gems in there. But just to say for Jess, I do have a question for you. And hypermobility, it's one area that actually I didn't know too much about until recently. And I guess a double-barrel question would be, firstly, why do you think it has taken longer than we might have anticipated for hypermobility to enter the conversation? And also, what could a screening program look like in, for instance, a mental health service?
Very, very interesting question, Timmy. I think
I put too much thought into them, Jess, I think.
I think one thing I'm going to say could sound controversial. I think hypermobility predominantly affects women, and women's issues are not always at the top of the agenda, medically, politically, or on a societal level. I also think that it's one of these things that is relatively new. And when we were publishing about the link between hypermobility and neurodiversity or neurodivergence, I got a fair few people saying, but why doesn't my doctor know this? Which is fair enough, but also it is relatively fresh knowledge. I mean, it is things that are only really coming together in the last 10 years or so, although people have been anecdotally talking about it for much longer. I think that hypermobility is associated with a lot of conditions where people are often dismissed or overlooked. So, gut issues, anxiety issues, irritable bladder issues, menstrual issues, and I think there is an intersect there in terms of complex physical health, mental health, and neurodevelopment, which means that people are often doubly or even triply disadvantaged because of being poorly understood. And also the education is not. I barely learn anything about hypermobility at medical school. There was one tiny page in the cheese and onion. So that's the first answer to the question, but I don't think it's necessarily malintentioned. I think it's a question of bringing the knowledge levels up. Now, what would a hypermobility screening program look like on a practical level in services? I don't think we're going to train everyone to do a full examination. I think that's beyond the scope, because that doesn't even happen in rheumatology. I think being curious and notice, and the self-report questionnaire, just 5 items, I think would make a huge help, and going prompted from that to ask about common physical health difficulties as well. I think would make a big difference. But the real trouble that we have, sorry, I'm wittering on. The real trouble that we have is properly identifying hypermobility in young people, because obviously hypermobility declines with age, and an awful lot of children are hypermobile. So trying to work out, it's quite easy to diagnose and screen adults, but working out a good screening tool for hypermobility in children, I think, should be a research priority of the future.
Sure, and just to move ahead now, Connor, you are in my crosshairs for a question. I want you to know that. Rest assured, I haven't forgotten you. But just something that Jess said encouraged me to move ahead to a key area, and that's intersectionality. Because something I'm really taking forward from today, when I saw your slides, Connor, about people of Black Caribbean extraction, and also Margot's slides just a few moments ago mentioning ADHD in women, I think the intersectionality of neurodiversity and women and ethnicity is something which, now don't get me wrong, I have a worry for everyone, including white men. I think there are issues there as well, but I think the issue of race, ethnicity, and indeed gender are really, really key areas. And I'm just wondering, if we're looking at ensuring equity in our health services, so equity in our health services, what can we do around that point of intersectionality?
Is this question for me?
Oh, well, go on. You can take it. Why not?
We have been thinking about this question, particularly as it applies to ethnicity in our service in Leeds. My colleague Kerry Lodge is currently doing a sort of service evaluation project, which hopefully will convert into a research project in due course into this. And it was prompted by the observation that it seemed on the face of it that we were getting fewer referrals from Black and Asian communities in Leeds compared to the proportion of the Leeds population of those groups. And so we've been doing a little bit of digging into that. It does seem to be correct that those ethnic groups are underrepresented in terms of coming forward for autism assessment. And a researcher, a colleague of mine called Sam Tromans, has also looked into this on a sort of UK-wide scale and concluded much the same. So our next bit of that project is to try and explore why that might be. And the initial findings there seem to point to perhaps cultural differences about the way autism is seen, and higher levels of stigma in those communities as one of the factors, at least. But I think we'll need to do a bit more work on elucidating what the other factors may be.
Thank you, Connor. And I see Bernadette and Jess.
Yes, thank you. Well, I speak for the United States, where I've been working for the last 25 years. I mean, it is a systemic discrimination, of course, vis-a-vis non-white people in general. It was already well known. African American are more often, for instance, diagnosed with schizophrenia, even if they're not. They're given higher dose. They are treated later for high blood pressure because supposedly their blood pressure can be higher. So we have centuries of discriminations. And we have studies recently showing that Hispanic children, for instance, would be diagnosed 2-3 years after a white kid for autism and receive treatment when they can later. So there's certainly a big issue there, which is a general issue in the mental health system. I want to add one other discrimination at the intersectionality, which is for transgender population. We know that the transgender population is probably 30% are autistic, and same autistic are much higher number of transgender. And you probably heard what's happening in the States, where old care can be removed in states like Florida. I mean, it's absolutely horrible. But what is even more insidious is when autism is used against the person, saying again, they don't have the ability to know if they want surgery or not, to know if they can identify their gender well or not, which I think is incredible. And that's a little bit in my speech about, they have no theory of mind, they know mind enough, and they cannot. I think that's one of the absolutely horrible discrimination.
Thank you, Bernadette and Jess.
Oh, I was just going to echo Bernadette's thoughts there, actually, about these levels of intersection and about them being sometimes used against each other. A bit like the previous speaker, talking about difficulties accessing ADHD care if you have a mental health problem. When you have lots of different issues that often come together and you are marginalized, using one as a barrier to accessing care for the other is just doubly or triply disadvantageous. And we were just thinking about that in our service. And this is what Bernadette was talking about in terms of trans health. And maybe it's being in Brighton, but we see a lot of trans and non-binary people in our service. And the difficulties accessing gender affirming care, if you are also neurodivergent, could potentially, that there's some moves to suggest you need a diagnosis before you can access that sort of care. And then the delays, because both systems have so much delay in them that it's going to be almost impossible for everyone to be seen. You can see if one delay is also dependent on another, the people are going to be waiting their whole lives. And we really need to think about how we support people better.
Thank you, Jess. Eva?
Yeah, I just wanted to sort of like also follow up on this point with the particular case of neurodivergent children in foster care, because I think this is another group of children who have a kind of, double hit in the sense that they might find it very difficult to be in different foster homes. In the UK, it's very common that children are in multiple foster places, even if in preschool age or in school age. And, you know, changes are particularly difficult for autistic children, for example. Then how about like really important life changes, such as being placed in a new family? And then children from non-white backgrounds are, again, harder to be placed. So they might be non-white and have a neurodevelopmental condition, and have nobody really to advocate for them.
And actually, the point about advocacy is really important, because I know there's a number of healthcare professionals in the audience today, and I think being able to advocate for seldom heard voices is so important. So maybe there needs to be more on educational programs as to how we advocate. Just a quick question for the panel on the issue of socioeconomic status and access, because again, thinking of some of the earlier presentations, I think Conor mentioned about a wait list of 125,000 people in England, I think it was, for autism assessment. And I know this is an issue in many countries. I don't have a panacea for it, but certainly access must be based on need, surely. Does anybody have any comments on how we can support everybody to gain access to services? Oh, Jess.
Hi, yeah, sorry. I think this is a potentially controversial comment, but I suppose that's the point of a panel, is Conor has told you about the number, the waiting list issue. And that may even just be the tip of the iceberg. His figures, I think in his graph, there was definitely showing quite an exponential curve to it. I think, and I may be doing myself out of a job here, but I think we have to rethink how we provide services, not necessarily ration them according to highest need, but upskill people so that autism isn't a specialist business, is my feeling. It is potentially a controversial statement, but I think ADHD, autism are actually more common than we think, or they're certainly being more commonly requested assessments for. We would have to clone people like Conor and I hundreds of times, even locally, to meet the demand to see everyone on the waiting list, and that there aren't enough people trained. So I think we really need to work out some way of embedding this in curriculum and multidisciplinary, so that general psychiatrists feel confident and equipped to diagnose neurodivergent conditions, and even possibly for ADHD, maybe GPs over a number of sessions. Again, a radical statement here, but the way the waiting lists are, there is no alternative. We can't clone people. But I know that Conor's in the Royal College of Psychiatrists, they're trying to skill up psychiatrists with the National Autism Training Programme, which I think is a great idea. But we have to come out of the ivory tower of our specialist clinics, I think.
Good point, Jess. And Bernadette and Conor.
Yes, I totally agree, Jess. I don't think it's radical. I think it's practical and it's real. I think we certainly need to inform and educate and quote all physicians, by the way, and healthcare provider, at least, to be able to identify, understand. And I don't see why psychiatrists, once they're trained, cannot give a diagnosis, maybe not a neuropsychological one, but for God's sake, I think schizophrenia takes so much time in training. And I don't say it's not important, but it's 25% part of the population we have today as people who identify as autistic. So I think it's vital. There's a nonprofit organization I work with in the US, and their goal is ambitious, but really trying to bring, we have what we call CME, so the classes, so the training doctors are mandated to take every year, really to try to increase that level and to really train psychiatrists to give a diagnosis. No, I think the controversial part is because of money. And then some people may be worried or be out of a job, and had this discussion with my neuropsychologist. We think, but we need more people. So I feel that absolutely. And the other thing too, I work in nonprofit, work with a nonprofit in LA for 20 years. And the last 5 years, I've done a lot of work. So we worked only with the homeless refugee population, people with no insurance at all. A lot of children actually are identified where they are in school, and we see the parents. And I'm really working to train social worker, nurses, people with whom we collaborate. So I think information, very essential.
Great. And Connor?
Yeah, I broadly agree with Jess and Bernadette that the demand is such for both autism and ADHD that the model going forward has to be one of more generalists getting involved in this area. And so I'm keen in my work with the Royal College to advocate for psychiatrists, general psychiatrists, to become more confident and more skilled in assessing and ultimately diagnosing autism, and that's one of the driving forces behind the new national training program for psychiatrists we've launched. I think the difficulty, as with everything in the health service at the moment, certainly in the UK and I suspect in Ireland as well, is that the entire health service is saturated with demand, and our general psychiatry teams, they can't even meet the demand for their core business of managing major mental illnesses like schizophrenia and bipolar disorder. So the appetite for sort of introducing neurodevelopmental work on top of that at the moment is very limited. But I do think that's the direction that we have to go in future in terms of both service development and skilling up our workforce.
Okay. And just speaking of the workforce, when we think of equity, how about the workforce, and how about having more people who identify as neurodivergent or autistic or dyslexic or any experience we can think of? How about having a workforce which is more diverse? There has been a lot of work, in my view, rightfully, in areas of equality, diversity, and inclusion. But I wonder if there's more work to be done in ensuring that healthcare professionals, for example, can speak more openly about their own experience of being neurodifferent or being neurodivergent, whichever term a person may like to use. Is there more work to be done to welcome people with the various experiences into healthcare? Bernadette.
Sorry, I'm very passionate about all this, as you know. And the reason why I came out in a way as an autistic psychiatrist is because nobody can fire me and I'm not going to lose grants. It's very scary for many psychiatrists, I can speak for them, and residents, for instance, because of the old stereotypes that I spent a long time to try to dismiss. Right. And we have cases of residents who suddenly, are not well or ever diagnosed with autism, are autistic, and a residency program director or physicians who will see that person will say, oh, autistic, no empathy, no theory of mind. How could they be a psychiatrist, right? And they may be kicked out of a program. So you really have that problem, very important in the coming years, of people who've been as young people identify, that's who they are, and may pay the price for that. But I'd like being gay 30 years ago, right? Oh, you cannot be gay, you're a psychiatrist. You cannot be psychiatrist, okay. And so that's really a very big issue, I think. And again, education and information and advocacy from inside will be very important, saying, oh, yes, you have empathy. Maybe your theories were not correct. So that's super important. And we need a neurodiverse workforce, absolutely. Remember the double empathy problem. We can work with everybody. I can see men, I can see people who are different, but it's clear that there is a click that will happen between me and a neurodivergent patient that I may not have the same way with someone who is neurotypical.
And I fear that this is happening a little bit in nursing as well, that again, sometimes the standards and requirements to become a nurse, they're adjudicated according to a neurotypical standard, and that may exclude people who are not neurotypical. So yeah, I think it's a good point, Bernadette. Jess and Connor.
I completely agree with what Bernadette said, but I think we need to put our money where our mouth is, and that means, well, not our money, I suppose, the system's money. That means a bit like the previous speaker was talking about, people who come to university late and then maybe fall through the cracks. It's all very well advocating for a neurodiverse workforce, which we absolutely need, and is that the right structures and support need to be in place. So I'm very proud to work in a trust that has a neurodivergent staff network. And also we are, I believe, one of the first trusts in the country to have our own neurodevelopmental staff clinic, which means that NHS staff in our psychiatric trust, you know, be they admin workers, OTs, nurses, can have access to diagnostic assessments, primarily to support them at work and thrive in the workforce. And so I would say you need to back up, people need to back up statements about EDI with actual investment. It's like widening participation to university without providing the right study support skills and infrastructure for those students.
Well said, Jess. Connor.
That sounds like a fantastic scheme in your trust, Jess. You'll have to send me some details about that. I'd love to approach my trust to replicate it. My reflection on this, I became the Royal College Autism Champion about 2 years ago, and maybe naively, I thought it would be all about autism diagnostic services and improving mental health services for autistic patients. What I hadn't quite counted on was the amount of interest there is in autism in the workforce and neurodivergence in the workforce. So I've been approached by a number of psychiatrists who are autistic or neurodivergent, a number of trainees. Spoke to a trainee last week up in Scotland who was telling me that she's just found training so incredibly difficult. It actually precipitated a mental health crisis, and it was all to do with the unpredictability of the shift work and also moving around a rotation every 4 months, which is what you have to do in the foundation training. So that kind of inconsistency and constant change was just really challenging for her. But I think there's beginning to be a change. I think probably 5 years ago, as I was kind of even quite oblivious to it myself, but 5 years ago, people in the medical profession didn't speak about being autistic or neurodivergent. And I think it's down to trailblazers like Mary Doherty, who's here today, and you, Bernadette, who are open about it and reassuring, I think, others that it's okay, and we have a lot of autistic and neurodivergent people in the mental health workforce.
Okay. So in terms of equity, just to maybe call myself out here a little bit, I mean, it struck me that as one of the members of the organizing committee, perhaps we could have brought more focus to areas such as dyslexia and dyspraxia, dyscalculia, Tourette's even. And I wonder, could this be reflective of, it might be reflective of maybe a bias of mine, but is it reflective of perhaps a bias in the neurodiversity movement itself? Is that something that we need to consider when reflecting on equity? Jess?
Again, I think it's very different for different people, but I think for some people, neurodiversity and neurodivergence is synonymous with autism only. And I think that a lot of the way the NHS England focuses on autism rather than other neurodivergent conditions is I feel that, because I do some clinical work and research in Tourette, for example, I feel that sometimes ADHD and Tourette and dyslexia and dyscalculia risk being the poor cousins. Again, this could be controversial, but I think we need to look at everything in the broad and not get into kind of turf wars over different nomenclatures. And the research and our clinical work suggests that these things so often go together more than they stand alone. So, but I think ADHD and Tourette have a very limited voice often in terms of research and organizations in comparison to autism. And we must think about all neurodivergence and also the importance of dyslexia and dyscalculia. I know they're not medical conditions and you don't see a psychiatrist to get diagnosed, but if you're an adult and you're not in education, how are you supposed to get a diagnosis without paying for an incredibly expensive assessment? I have colleagues who suspect they may have dyslexia or dyspraxia, and our occupational health department, even though we work in the NHS, one of the largest organizations in the world probably, says you need to fund that yourself. And we need visibility and awareness of all of these things, and not to fall into factions is what I think.
Sure, and just to go on a little soliloquy, I mean, one of the things which is on my mind, and it came from the comments or the questions, is how we can design pathways for people who identify as neurodivergent to access high quality mental health services. Because for too long there has been a dichotomy whereby it's felt that, well, maybe I don't need to know about autism, you know, because autism isn't a mental illness. But this has created a barrier. But of course, other experiences as well, dyslexia, for instance, if a person is excluded from education, this will affect self-worth and self-esteem. So again, access and equity to the mental health services. Bernadette, you'd like to come in?
I commented a little sideways because I saw in the same ways a question from Gabby about how to increase resilience. And because there are two things: how do we increase access, right? More education. I'm not in the English system. I'm not totally sure. It seems pretty difficult in the state too. But I think what's very positive when you have a neurodivergence, and I apologize, the one I know best is the one I talk about, knowing more about yourself, being more knowledgeable. It's really extremely important in being able to set limits properly, to protect yourself better, to make sure you sleep, what you eat. I mean, things that are no medication related, that really being able to make these decisions and set limits without feeling guilty. Because the problem, I think, with a lot of therapy, from psychoanalysis to behavioral activation, is that it may work for some people, but it can so be totally counterproductive. And you're a good student, you really try to change, and there are things you cannot change. What you have to do is to protect yourself, be able to set limits, discuss that with your partner. You know, I'm not going to go to that evening party, and manage that. So I think there is a lot of things, and there's a lot of books out there by neurodivergent people or other that can help. And I'm sorry, it's not direct question to answer to your question, but I think people need to know there are resources out there, and you want to use them and get to know yourself better and say, okay, I'm going to say no, and I'm fine. I'm not a bad person. I'm not lazy. I'm just different.
Thank you, Bernadette. And Eva, a little earlier when I was listening to your talk, it crossed my mind, I want to be more like you. I was envious of the very successful studies you've ran, something to try to aspire to. However, given your knowledge of the European context, is there equity, would you say, for research into areas of neurodifference, neurodivergence? Is it a scrap out there to try to get funds, or are we pushing an open door at the moment?
No, I wish the latter was the case, but I think we're going rather in the opposite direction. I think in the past, the UK was probably one of the countries in Europe who had received, relatively speaking, relatively a lot of funding. But of course, now with Brexit, these things are beginning to change, in that the UK is no longer eligible for European funding, which has become one of the biggest sort of like funders, like the European Commission, for example. There is rather a lot of differences across European countries, including Eastern European countries are really underrepresented. Also in Germany and in France, for example, autism research had been really underfunded. Again, it's like different perspectives and traditions that people have been working in France. For a long time, it's still been in a psychoanalytic tradition. So definitely there's a lot of differences across European. Sweden, for example, is relatively well funded, especially for epidemiological studies. So huge differences. Unfortunately, my impression is it's altogether getting even, the pot gets even smaller oftentimes. It's getting rather more difficult and easier to get funding.
That's concerning. One might have hoped that the answer would be the opposite, as awareness and public discussion is growing, that there might be more funding, but your lived experience of it isn't that anyhow, Eva, at the moment.
I hope I'm wrong, but that's my impression. However, there are also good things to say. For example, I think on the whole, funders are really getting more generally interested in participatory research. That's not only within autism research, but also, for example, global mental health, where this is being taken more seriously. So there are also other more positive trends.
Okay. Now, before I delve into some questions from the audience, Connor, I did say I wouldn't forget you. Earlier, when you were speaking, I took a note because I found it really interesting. In your presentation, you spoke about misdiagnosis of autism and borderline personality disorder. You mentioned a study which indicates that that's relatively low. And I'm just wondering, what's your view on the sense that misdiagnosis is a lot bigger, when the research evidence suggests it's quite low? Do you have any views on why there might be a perception that the misdiagnosis is higher?
Yeah, there's certainly a lot of anecdotal evidence that this seems to happen. The study that I cited in my presentation was a systematic review from 2021, which looked at all the previously published studies in this area. But I think the main takeaway from that was that they're all pretty small scale, all based on selective clinic samples, use different methodology, and have quite variable range in terms of the overlap between borderline personality disorder and autism. So it's very hard, I think, to draw any really firm conclusions from the existing literature. Speaking from my own clinical experience, there's no question that I've certainly seen patients with a long-term diagnosis of borderline personality disorder, and when we've assessed them for autism, they're very clearly autistic. And then it raises the question in our multidisciplinary team meetings over whether it's their autism that is driving this sort of self-harming behaviors and emotional dysregulation and so on that's led to the BPD diagnosis, or do they have both? And I think it's probably some of the nuances sometimes missed in the debate. It becomes a very either or binary situation, and I think it probably is. There are people out there who meet the criteria for both diagnoses. But my intuition is that if we looked at the existing population of particularly women with a BPD diagnosis, if we looked hard enough, we would find that a pretty big proportion of them are in fact autistic.
Thank you, Connor. And Bernadette and Jess?
Yes, I would agree. I mean, that's how I came to discover kind of autism in women and my own. And my specialty had been for many years working with women who were referred to me for borderline personality disorder, and which didn't look at as a negative thing at all, and really work with practitioners doing some time DBT. And it was clearly a number of the patients I would see, they're not totally fitting. Yes, the symptom, the behavior, right, as you said, and you can see that if you go slow in my slides. I really took a slide just to make this difference and similarity, and Connor spoke about that too. There are differences when you look at the history of the emotions and the different things, but they have been misdiagnosed for a very long time. And a lot of women borderline have been misdiagnosed as bipolar because the doctors see them for 15 minutes and it's easy to give a mood stabilizer more than get to know the patient and work with them. So there's a lot of misdiagnosis there. They are trying to adapt to DBT, for instance, for neurodivergent people. They have a couple of books, and I've been really working in the States with psychologists interested to adapt and working really with the patient to adapt. You want to identify emotion, you want to learn emotional regulations. At the same time, some of the groups are not necessarily something that someone who is autistic will go easily to. So there's a lot of work there, but I think there's much more. Seems the numbers you were showing, Connor, seem very low indeed. I would suspect it's more than that.
Thanks, Bernadette. Jess?
Yeah, so much to say in this space, and I think it is a big area that really needs robust research, because as Connor said, the systematic review limited by small studies, we really don't know what autism prevalence is when thinking about it in a slightly, with the female perspective and things. And so we need much bigger studies to really work that out. But I think we also have to question our labels and where they come from and how they evolve. And we use psychiatric diagnoses. In some ways they come and go, and various things, they morph and change, and maybe there are elements. Is it misdiagnosis, undiagnosis, co-diagnosis? Philosophically, it's so hard to tease all of that apart because of the product of the diagnostic criteria. And I think that's why I don't know if people are familiar with it came out of the NIHR, the RDoC classification, where you kind of think in dimensions of things rather than necessarily categories all of the time. So things like ADHD, autism, bipolar disorder, what we call emotionally unstable personality disorder or borderline, all have shared features. And in one person, you may have some of these features at any one point in the lifespan. So kind of taking a personalized approach rather than necessarily a heavily label driven approach to strength and challenge, I think is really, really important. And there was something else I wanted to say, but yeah, we need more research. We also must understand that these terms are fluid, and to a degree have been a clinical consensus. They're not drawn in stone, but it is something. I think opening up a conversation about this can be so important in terms of being able to validate patients' experiences, is talking about what it felt to be diagnosed as having EUPD versus what it feels like to be diagnosed as autistic. And myself and Seb Shaw have a master's student just submitted on that at the moment, a qualitative study exploring those overlaps. And And I had a clinical anecdote in that sometimes people could definitely meet the criteria for 2, but I think you can get a diagnosis of EUPD in minutes in a psychiatric environment compared to an autism diagnosis. And I was recruiting someone for a hypermobility study, and we were doing, we were talking, it was an assessment, and they said they had an EUPD diagnosis and had been on a DBT program. And I asked about recent suicidal ideation and what had prompted it. And they said it was because someone had moved the spoons in the drawer. And now thinking about that is completely different to thinking about some of the more interpersonal triggers that you might think of in EUPD. But sorry, I am rambling, but I'm getting to the point. There is so much, when you talk to autistic people who also have who self-harm, there is so much interesting information that the biomedical science community need to take on board about the role of sensory regulation, dissociation, interoception, and how self-harm is often in response to what you might think of as autistic overwhelm. It's sensory overwhelm, mixed communication messages, things not being predictable or routine being disrupted. And when you put that neurodivergent lens on distress, it can make a huge difference to understanding.
Absolutely agree, Jess.
Sorry, that was a bit long.
So just in terms, I do have a question to wrap up with, and I just want to ask one question. We've sought to answer some questions in the Q&A. There's one question in the Q&A, but just to get you thinking about this last one as well. In terms of healthcare professionals, what can healthcare professionals, if there was one point from each of you that healthcare professionals could do to boost equity in mental health in the area of neurodivergence, what would that be? Now, before we get to that question, just think about that for a moment. Before we get to that question, I see 1 or 2 questions from people looking for resources, somebody who is finding it so hard to get a diagnosis, is thinking about giving up, is wondering about support groups. They happen to be based in the UK, but I'm just wondering, would you have any guidance for somebody who doesn't feel able to keep pushing for a diagnosis? Would you have any guidance around support services, perhaps in the UK, or resources more generally for non-professionals? And then that final question, just to wrap up. Jess.
A Mind advocate, so perhaps getting an advocate from the charity Mind to do some of the advocacy work so that is less traumatic potentially. No.
Okay, thank you for that. Just in terms of that wrap-up question, and I mean, for me, I'd like to go off and write a comment piece about what mental health nurses can do to support people who are neurodivergent. Specifically, autism actually is one I'd like to write about, just based on some of the talks today. But if you could briefly make a comment on what you think healthcare professionals can do around ensuring equity in mental health as your concluding comment, I'd be grateful. I see Bernadette, Connor, Jess, and Eva.
It will be simple. Believe the patient. Know what you don't know. Know that you may not know about, what's going on. If they tell you they have side effect with a super low dose of medication, trust them. If they tell you it doesn't work with a regular dose, it doesn't work. We can do that with all patients, of course, but doctors are so scared, ignorant how the mind and the body of a neurodivergent person function, that they have doubt. If they could only be a little more humble and say, okay, I don't know, you're telling me that, I'm going to look into it, and believe them.
Thank you.
Well, Bernadette, you stole my my answer. I was going to say more or less the same thing. Yeah, I was going to say mental health professionals need to be willing to, again, believe the patient and believe the patient's autism diagnosis. The case of Zoe Zaremba that I mentioned earlier, the young girl who died by suicide, part of the issue there was that healthcare professionals were so used to seeing self-harming behavior through a borderline personality disorder lens that they kind of forgot about the autism that had actually been diagnosed in childhood. I had a similar example where, again, a female with a BPD diagnosis, in fact, was autism, and we diagnosed her with autism, and the ward that she was on really ran with that, made lots of reasonable adjustments, managed to reduce her medication regime from 13 different medications down to 3, and discharged her. But then she was admitted again a few months later to a different ward where they really weren't on board with the autism formulation, and treated everything again as more of a BPD presentation, and the patient actually deteriorated in a mental state again. So sometimes getting that buy-in from mental health professionals is key. And if I can be greedy, Timmy, I'll say one other point is always ask if there's a health or hospital passport, and if there is, make sure to read it. That's the big takeaway for me from the tragic story of Oliver McGowan, when they didn't read the health passport and therefore didn't know that he was sensitive to antipsychotics.
Thank you, Connor.
Sorry,
Jess?
before Jess, I just want to insist, we don't treat catatonia with antipsychotic medications. But just what at the APA, we shouldn't use them. And I know it's been said this morning, but yes, that's a mistake. Sorry.
I was going to say snap to Bernadette and Connor, but I'll rephrase it slightly. Listen and be prepared to learn. I remember being at a conference where there was, because I come from this hypermobility research background, where there was a cartoon of a patient saying to their doctor, I think I have EDS, POTS, MCAS. These are hypermobility related conditions. And the doctor saying, I haven't heard of these, you can't. And it's that idea that you need to learn from the patient, listen to the patient. There is so much more out there in this world than we can possibly dream of or have been taught at medical school. So please listen. Very few people are going to talk to you and actually fabricate what they're saying. They're genuinely saying it. So listen, and if you don't understand, ask again, speak to someone with the condition, look it up and find out. But don't dismiss what you don't understand or are afraid of.
Yeah, I mean, what I'm hearing actually is respecting people's expertise in their own life and their knowledge of themselves, and to really challenge any paternalistic leanings that any of us might have. We really need to challenge that. Eva, concluding words.
Well, I can speak mainly to that from a research sort of like context. And what I would say is really sharing resources, sharing information, knowledge between labs, between countries, with early career researchers. Now, this is a new generation. They are growing up in a completely different research culture than my generation or other generations before us. They are the ones who are growing up in a neurodiversity affirmative kind of framework. And that's what's going to probably promote change, within the research setting, the health settings, education settings, beyond that.
Yes, and I think, just reflecting back on today, I know, Bernadette, it might have been your slides. Forgive me if I'm wrong, but the value of being more kind and being more welcoming and more respectful, actually, of all of our different areas of knowledge and expertise could go a long way. But certainly, I know as we conclude the panel discussion, Mary Doherty is going to sum up the conference today and over the last couple of days. But it's a real pleasure having this chance to speak with everybody. Thank you for being so open and candid in your thoughts. So Mary, if you're available.
Thanks, Terry. What an amazing discussion. I really didn't want that to end. We could go on for a while, but we do have to come to an end. But just want to say what a privilege it has been to be part of this groundbreaking conference. And and I really want to just start by thanking the co-organizers, in particular the clinical team, Drs. Blonard Gavin and Timmy Frawley, for their foresight and vision in planning this conference, and for bringing the team together. We've had Ken Kilbride from ADHD Ireland, Andrew Eddy from Neurodiversity Hub, Charlotte Valeur from the Institute of Neurodiversity, and of course Beth Kilkenny for all the amazing organisation in the background and just keeping us all on track. And thanks to all of our speakers and our moderators and all of you for attending and for your thoughtful questions and comments throughout the sessions. I hope you've enjoyed the past 2 days as I have. I think we've brought together some of the most important international voices in the current autism and neurodiversity discourse. I hope you'll agree it was interesting and educational, but more than that, I hope you've been inspired by our amazing speakers. I think for me, the most important standout messages really is just the power of understanding autism and neurodivergence from the inside, and then moving away from that deficit framing, and how lack of understanding and stigma and stereotypes really negatively impact mental health for autistic and neurodivergent people, as well as the importance of remembering the brain-body connections, which we're just becoming aware of. Personally, I have no doubt that a neurodiversity affirmative approach to autism offers the potential for better mental health outcomes for all autistic people. And I really hope that practitioners will make that paradigm shift and incorporate these principles into daily practice and bring these messages back to your colleagues in your professional practice. Another key point is the importance of the autistic voice, both in co-production, in research, and in professional practice. And we've heard from a range of autistic professionals in healthcare and education, and in particular, I want to thank those of you who shared personal experiences. We know it's not yet safe for many of our autistic colleagues, many autistic professionals, to be openly autistic. And I've no doubt that events like this can have an enormous role in changing that reality. We've had some challenging, potentially triggering moments. So if you have been impacted emotionally, please do take care of yourselves and do reach out to your support networks as needed. For some of you, the talks may have resonated on a really deep personal level, and you may well have had that light bulb moment realizing that you may be neurodivergent yourself. And while that can be an emotional journey, know that there's a growing community of autistic and neurodivergent professionals in all fields. Finally, just to say, we've had a global audience and we've had participants from many countries across the world, but we're also local. We're based here in Ireland, and as we start our journey here in Ireland towards developing neurodevelopmental services, and in particular equitable provision of mental health services for autistic people, I really hope that those of you in clinical services have been inspired to make that paradigm shift away from that core deficit model towards that neurodiversity paradigm. I absolutely share Dr. Margot Wrigley's dream for a combined neurodevelopmental pathway, and I've seen the benefit of that approach elsewhere where it is already working. So therefore, when you go back to whatever services you're working in, whether physical health, mental health services, education, or other sectors, because of course the first step to meeting autistic needs is recognition. Do look out for autistic people in whatever area you work in, because we're everywhere, including amongst your colleagues. But really importantly, remember, you don't need to wait for an assessment or a diagnosis to make accommodations for autistic people. As mentioned earlier, you might find the SPACE framework helpful in that regard. My hope is that when autistic people experience mental illness, autism understanding and meeting autism-specific needs will accelerate recovery, and that shifting that paradigm much more widely will contribute to the prevention of mental ill health for future generations of autistic people. So finally, once again, I just want to say thank you for attending. Links to the recordings will be available soon. And with that, I wish you all a good weekend. Thank you.
Thank you for organizing. Thank you, Mary, for everything. Thank you.
Thank you so much.
Thank you. It was amazing.